Let us now talk about the oral contraceptive pills. OCP stands for the oral contraceptive pills. This oral contraceptive pills are simple oral pills which provide contraception, right? So there are different ways to think on the full form of OCP. OCP could also be a oral combined pill. So talking about the oral combined pill, which is available in Government of India, oral combined pill. It contains both estrogen and the progesterone. That's the reason it is called as combined pill. So MCQs on the OC pills or the oral combined pills. In India, we are having OC pills in form of Mala N or the Mala D. Mala N or Mala D, they both contain, Mala N or Mala D, they both contain ethinyl estradiol. They both contain ethinyl estradiol at the rate of 0.03 milligrams. And they both contain levonorgestrel at the tune of 0.15 milligrams. So please note that either Mala N or Mala D, they both contain ethinyl estradiol and levonorgestrel. So what's the fun of having different Mala N or Mala D? Please note that Mala N is given free of cost in India. Mala N is available as free of cost. There is no charge on Mala N. Whereas Mala D is available under a special name, I'm going to say, that is called as social marketing scheme. It is available under a special name called as social marketing scheme. What's this all about? You can remember or you can relate it somehow that the ASHA worker, you remember there are ASHA workers in the village? So the ASHA workers, we have given them incentives. That they can give home delivery of these contraception. So that phenomena of giving incentive to the ASHA workers for the contraceptions which are already available under the Government of India, that phenomena we've called it as a SMS scheme, social marketing scheme. So that under the SMS program, under the social marketing scheme system for the ASHA workers, they will deliver the OCPs, oral contraceptive pills, which one? The Mala D tablets at the rate of ₹1 for one packet of OC pills. For one packet of OC pills, they will be giving at the rate of ₹1. Different states have different numbers, but generally it is said that under the RCH program, the ASHA can give these contraception at the rate of ₹1. That is what contraception? That is the Mala D tablets under the social marketing scheme. However, if this is a female, she comes to us in the sub-center. If this female comes to us in the sub-center, then we can give her Mala N tablet, for which we will not charge any rupees. Just remember, Mala N is given by the nation. Nation is free of cost. Mala D is available from the Dukan. It is for delivery. You can remember that D for delivery, D for Dukan. You can remember that Mala D is available at a minor charge of ₹1 per packet of the OC pills. Please note that Mala N or Mala D, they both contain the same constituents. Mala N is 0.03 milligram of ethinyl estradiol and levonorgestrel 0.15. Please also note that both Mala N or Mala D, both of them, they will contain 21 hormonal tablets and 7 iron sulfate tablets. They both contain the same amount of 28 tablets. Earlier it was Mala N contains 21, Mala D contains 28. Now it is same. Mala N or Mala D, they both contain 21 hormonal tablets and 8 iron folic acid. So if we just look at the Mala N or the Mala D tablets, as you can see over here, this is the packet constituent for Mala N, and you can see Mala D. Can you read the name Mala N? Mala N, you can see, is under the national program. This is free supply. Can you read this? This is a small written. It's a free supply, not for sale. And this over here is Mala D, and I don't know how much you can see it, but if you can, I'm sorry for the small image, but if you can appreciate, there is nothing written over here. This is a free supply. Mala N is a free supply. Mala D is no free supply. Mala D, ₹1 for one packet. Mala N, free of cost. And they both, can you see, they both contain 21 hormonal tablets, and they both contain only iron tablets. So please note they contain the same constituents. If you look at another one, if you just open this packet for Mala D, if you open this packet, this packet will contain 28 hormonal tablets, and you have the 7 iron tablets, that is the iron sulfate, ferrous sulfate tablets. So these are some of the things you need to remember and know about Mala N and Mala D. So now, apart from this, you should also know that as far as the OC pills are concerned, what are these side effects? We are going to talk about the side effects of oral contraceptive pills. The side effects can broadly be classified into 3 side effects. We can talk about the metabolic side effects of oral contraceptive pills. We can also talk about the cardiovascular side effects of the oral contraceptive pills, or we can also talk about the malignant potential or the cancer producing or the malignant potential of the oral contraceptive pills. So what are the metabolic side effects? Metabolic side effects means something happens to the metabolism in the body. So basically we are more bothered with the weight gain, or obesity may be a side effect. The second side effect, metabolic side effect, could be dyslipidemias. Okay. Regarding the cardiovascular side effects, I have somehow memorized that in my brain, in my mind, I have made a picture of atherosclerosis for oral contraceptive pills. So I have just memorized this word atherosclerosis. So that means what? Like atherosclerosis means what? It means more blood pressures. It means hypertension. Atherosclerosis also means coronary artery disease. Atherosclerosis also means cerebrovascular stroke. It means cerebrovascular stroke. It also means atherosclerosis somehow also means deep vein thrombosis, cerebrovascular stroke, deep vein thrombosis, coronary artery disease, hypertension. It will also mean pulmonary embolism or other thromboembolism. So every word I have just related with the word atherosclerosis, right? Secondly, as far as the malignancy is concerned, as far as the malignant potential or the cancer producing side effect of the oral contraceptive is concerned, you can see that I'll just share with you how I have learned, right? You can make your own way. So let us say that a female is there. This is the normal anatomy of a female. So the top organ we have is the breast in a female. Then there is ovary. Then there is endometrium. And in the lowest part is the cervix, right? So that's just the way I have remembered. I have remembered that the first organ, that is the top organ, the breast, and the lowest organ, that is the cervix, the malignant potential for these tend to increase with OC pills. I have also remembered that the middle organs, that is the ovary and the endometrium, the malignant potential for these tend to decrease with OC pills. That's just my way of remembering. You can devise your own way. So I've remembered the top and the last organ, the cancer increase, the middle organ, the cancer will decrease, the malignancy. So if we just being asked about the malignancy of the OC pills, please note that OC pills tend to promote which cancers? They tend to promote a CA cervix more than the CA breast, but they will promote both the cancers. Please note CA cervix and CA breast both are promoted. If you get single best answer, CA cervix is a specific cancer for the oral contraceptive pills. Second is, which are the cancers which are protected? With OC pills, the cancer of the cancer ovary is more protected than the cancer endometrium. The specific answer for this would be CA ovary. Please note that if you get single best answer, it has to be CA ovary. Please also note it promotes another cancer, that is, it promotes the hepatocellular cancer or the hepatic cancer. Hepatic cancer is promoted. So just remember that predominantly OC pills have a role in promoting the liver cancers, the cervical cancers, and the breast cancers. So these are the things that I have just remembered as far as the malignancy cancers or the malignancy potential. They promote the cervical cancer, the breast cancer, and the hepatic cancers. And they protect the ovarian cancers and the endometrial cancer. So these are the side effects of OC pills in nutshell for you. So now, based on these side effects, what are the contraindications for oral contraceptive pills? If you talk about the oral contraceptive pills, contraindications now. The first and foremost contraindication is a thoughtless contraindication. I think it is very easy and common sense that what is the biggest contraindication? It is pregnancy. I know people from gynae will kill me for this, but pregnancy, please note, whenever we are prescribing any oral contraceptive pills, we have to be pretty sure that the female is non-pregnant. Apart from pregnancy, what are other important contraindications? First is regarding the age. Please note that as far as age is concerned, age more than 40 years is a big time contraindication for starting OC pills. And in case the female is, in case of, ICO stands for in case of the female is smoker. So in case of smoker, the age more than 35 is taken as a contraindication for starting OC pills. Third, very important and common sense again, any uterine bleeding, abnormal, undiagnosed uterine bleeding is a big time contraindication for both. Please say with me, undiagnosed uterine bleeding is a contraindication for OC pill as well as for the intrauterine devices. Both things cannot be inserted or started because common sense, right? Because if the female has any genital malignancy, what are you going to do? So any uterine bleeding should be diagnosed before we start with any method of contraception. Point number 4. In case a female has any problem regarding thrombus, you remember what was the side effect? Just now we talked about our side effects of oral contraceptive pills. You see that any person who has atherosclerosis, like what are the side effects of atherosclerosis, that is thrombus, any past history of thromboembolism or past history of deep vein thrombosis is a contraindication for OC pills. Any past history of coronary artery disease, cerebrovascular stroke in the patient, any case of cardiovascular disease or cerebrovascular stroke in a patient is again a big time contraindications. So these form some of the major contraindications. And of course, we forgot about the liver. Any serious liver or advanced stage liver disease, which is probably cirrhotic in nature, that is actually a contraindication for oral combined pills. So please note, anything which predisposes to these conditions, any female who has common sense, any female who has a breast malignancy, any female who has a breast cancer or who has any cancer in the body, any genital cancers, is common sense contraindication for oral contraceptive pills. So what we have done in OC pills is we have talked about the types of OC pills. We have talked about the side effects and the contraindications of OC pills. What is the mechanism of action of oral contraceptive pills? See, I think we all understand that giving Mala D or the Mala N to a female, it will cause only giving estrogen progesterone to this female. So if there is only exogenous estrogen progesterone, the body is endogenous. The body's estrogen progesterone is inhibited. So because there is less estrogen progesterone, the FSH LH will increase from the body, and this on day 21 suddenly you stop giving the estrogen progesterone, which causes a withdrawal bleed. So technically for your exam you just need to know that what is the mechanism. I think in detail you must have heard it during your gynae lectures, that what is the mechanism of action of OC pills. In one word, if you want to remember, it causes an ovulatory cycle. It causes an ovulatory cycles. It does cause withdrawal bleed, but that bleed in a female is not because of the estrogen progesterone from the body. It is because you are withdrawing the estrogen progesterone from the outside. So these is an ovulatory cycles. It inhibits the ovulation. Please note, there is no effect of the OC pills on fertilization or implantation. It inhibits the ovulation. Next is this implants and injectables. If you talk about implants for your exams, you need to talk about what do you mean by a Norplant? What is Implanon? And what is a Nexplanon? Implanon, Nexplanon, or the Norplant. Norplant, please note, all these implants that we are talking about, Nexplanon or the Implanon or the Norplant, all these implants, these are subcutaneous dermal implants. All these implants, these are subdermal implants. Norplant is made up of a material that is silicone and plastic. It is made up of silicone and plastic. So we call it as a silastic material. It's a silicone and plastic material, silastic material, which is available in different types. You can have the R6, you can have the R4, or we can have the R2 or a single R. So what does these R stand for? R stands for these are silastic rods. So these are subdermal implants and these are silastic rods, and you can see that the Norplant is like this, and the person is injecting the Norplant in the area, in the forearm or in the upper arm we can inject it, and these are what are the Norplants. Now what is this Implanon and Nexplanon? Nexplanon. The Implanon and Nexplanon, they contain the etonogestrel, and they are hormone secreting. They will usually secrete around 60 to 70 micrograms of hormone per day for around 30 to 60 days. 30 to 60 days after inserting, and then they will secrete anything between 25 to 30 micrograms a day for the remaining part of their life. Usually, Implanon and Nexplanon, they are applicable for 3 years. And these Implanon and Nexplanon, they are more advanced than the conventional Norplant. Please note, in Government of India, we are not giving any Norplant, Implanon or Nexplanon, but these are available for use in private sector. If you just look at the Implanon is more advanced. Like the Norplant, you can see was inserted using a trocar conventional. It's a big bore needle. The Implanon is a very minute fiber, small needle. It is very few millimeters, and it has a button you can see on the back side. It is with the button, you just press it and tuck, it goes inside. Nexplanon is still more, it's a more device. It's a much better device. You just take it and you insert it on the back side of the forearm. Usually it's in this area, and on the arm, on the upper arm, and the person will just do it like this, right? It's a simple device, and only one person is needed to just insert it directly. So these advanced forms, Implanon and Nexplanon, they are more advanced. They are easy to use. They are more advanced, and they have lesser side effects. Nexplanon can be asked in your exam that Nexplanon and Implanon, they both have the least failure rate. They are the most effective. Both Implanon and Nexplanon, they are the most effective contraceptions. If you get single best answer, of course, Nexplanon is much better than Implanon. Why? Because Nexplanon also has barium sulfate. That is, it has been made more radio opaque. So Nexplanon, you can write down that it is more radio opaque and has a distinct advantage over Implanon, because Implanon was still with the trocar and the needle, although the button was there, but the Nexplanon is with the stapler kind of thing, right? So these are some of the questions on implants. Coming over next is, what are the injectables? The injectables that we are using in our system of the Indian health system, we are going to talk about two injections, that is depomedroxyprogesterone acetate, DMPA, that is depomedroxyprogesterone acetate. And we need to talk about NET-N, that is norethistérone enanthate. So primarily we are using DMPAs and NET-N. DMPA is given at the dose of 150 milligrams. It is given in the dose of 150 milligrams intramuscular injection, and this is to be repeated every 90 days. So it is given every 3 monthly injections. Whereas on the other hand, the NET-N, norethistérone, you can remember, is given at the dose of 200 milligrams. It is given as intramuscular injections, and it is given as every 2 monthly injections. There is also another improvised version of the DMPA that is called as the SC-DMPA. What is SC-DMPA? It stands for the subcutaneous DMPA. It is given at the dose of 104 milligrams every 3 monthly injection. It is again given as subcutaneous injections, that is subcutaneous DMPA given at the dose of 104 milligrams subcutaneous. In Government of India, we have started using DMPA. That could be your potential 3 by 5 star MCQ. In DMPA is being used by the Government of India. We are providing free DMPA injections. These injections are by the name of Antra. The Antra injections are nothing but the DMPA injections. Antra injections are the DMPA injections which are given in the Government of India. You need to memorize this. Please note, Antra is given by the Government of India. So this, what you see on the screen, is Antra. Antra is launched under the Ministry of Health and Family Welfare. We now have Antra injections. The government has trained all the ANMs, the health workers, the nurses, and the doctors, of course, for giving the Antra injections. Antra is a very suitable injections where OC pills and intrauterine devices cannot be used. And please note that when we are giving Antra, we just clean the area, air dry the area, no need of spirit or anything, air dry the area, and then we will give the IM injectable Antra. Please remember, IM injectable Antra 150 milligrams given in 3 monthly injections given as intramuscular injections. So now we have covered most of your temporary methods of contraception. Let us talk about the other methods of contraception. The first method you need to remember is what is Centroman. Centroman. First MCQ, what is Centroman? Is it a male contraceptive? Please don't go behind this word man. It is not a man contraceptive. It's a female woman contraceptive. It is a weekly pill. It is a weekly pill to be consumed by the female. It's a female contraceptive. In Centroman, what's the main ingredient? Please note, it is 30 milligrams of methoxychroman hydrochloride is there, and this forms a active chemical, that is ormeloxifene. It forms an active chemical, ormeloxifene. So this is the active chemical which is there. So in Centroman, it is available in Government of India. The Centroman is available in Government of India by the brand name of Saheli. Now the Saheli has been stopped. There is no more use of Saheli. We now have a new Saheli. The name is Chaya. So please note that Chaya is the new name for Saheli. Saheli is Centroman, and it contains methoxychroman, and the active chemical of this methoxychroman is ormeloxifene. It is a weekly pill. Some more points about Centroman. Centroman, what is the mechanism of action of Centroman? We are discussing Centroman. What is the mechanism of action? Please note that the Centroman mechanism of action is, it is a SERM. What do you mean by SERM? SERM is selective estrogen receptor modulator. So it is a selective estrogen receptor modulator. It is the only known non-hormonal. It does not contain any hormone, right? It's a non-hormonal oral contraceptive. It's a non-hormonal oral contraceptive. So how do we give Centroman? It is given as twice weekly. It is given as twice weekly for the first 3 months. Followed by that, we give it as weekly, once weekly for the next month onwards. Next months, it is taken as once weekly. Now try understanding that the Centroman or the Saheli or the Chaya, whatever you want to call it, it is known to be having a very high efficacy. It is a very high efficacy. That means it's a very potent contraceptive device, pill, right? Now, because it's a very potent contraceptive pill, but it is known to have a higher failure rate also. Why do you think there is a higher failure rate? The failure rate, because it is a weekly pill, that causes kind of a low compliance. in the female. Let us say that we ask a female to eat a Centroman tablet on Sunday. We ask the female to eat the next tablet on next Sunday. Now, within Sunday to Sunday, so many things will happen in life. So there is a chance for a female to forget, and once she forgets, there is a chance of failure rate of this contraceptive. Please note that Saheli or Chaya, it is known to have high efficiency but low effectivity. So we say that Chaya or Centroman has high efficiency in terms of the contraceptive efficiency. It may have a low effectivity. It may have a low effectivity, specifically talking in populations which are not so educated. So these were a couple of questions on Chaya or Centroman that you would like to remember for your exam. Next contraceptive, we are still on the other methods. Next contraceptive you can remember is Gossypol. What is Gossypol? Gossypol is a Chinese cottonseed extract. It is therefore a natural extract. It is a natural contraceptive, right? There are no synthetic chemicals in Gossypol. What is the mechanism of action of Gossypol? It inhibits spermatogenesis, and therefore Gossypol is the one of the only known male contraceptives. It is one of the few known male contraceptive, that is Gossypol. What is the side effect of Gossypol? The side effect, it's a Chinese natural product. So natural product may work or it may fully work. Pakka ilaj, that is permanent azoospermia. Permanent azoospermia could be a permanent side effect of Gossypol, that is a male contraceptive, natural contraceptive. Another type of natural contraceptive you would like to just remember for your exam is either Today. What is Today? Today is it's a vaginal sponge. We already talked upon this sponge. It's a vaginal sponge. It contains a spermicidal, that is nonoxynol number 9. And this Today is a spermicidal which contains nonoxynol 9. It's a vaginal sponge. And this Today may be associated with higher chance of toxic shock syndrome. Next is, what is this Gynaeflix? There is another contraceptive you can remember as Gynaeflix. It is not, all these types are not available wherever I have told that they are available in the Government of India. That means they are available under the National Family Planning Program. Remaining all the contraceptives we are just discussing, they are not available in the program, but yes, they are available in India. Gynaeflix is a rimless intrauterine device. So it is just a chain of copper. So it's just a string of coppers tied with thread. So it is kind of more tied with thread. It is kind of more user-friendly kind of copper device, and these are also called as rimless intrauterine devices, that is Gynaeflix. Next is, some of the questions may be asked to you about emergency contraception. Please note, emergency contraception. What do you mean by emergency contraception? Emergency contraception we can provide to a female when there is unprotected intercourse. So in that case, we can give emergency contraception to the female. So there are various methods. One is a UZPE method. YUZPEE. UZPE's method. UZPE method is not used or not recommended by Government of India. It was used initially. It is higher dose of OC pills given to the female in a very short time. So UZPE method is not recommended. Now currently what the recommendations are, we can give intrauterine devices. Intrauterine devices are applicable till how much time of the unprotected intercourse we can give an intrauterine device. They are applicable to be effective within 5 days of unprotected intercourse, which is a reasonably good time. We can also give to the female LNG. What is this LNG? MCQs on LNG. LNG stands for levonorgestrel. What is the dose of levonorgestrel for unprotected intercourse or for emergency contraception? If you answer it was earlier 0.75 milligram given within 72 hours, and then another shot of 0.75 milligram given within 12 hours of the first dose. Now it is not observed anything like that. So now what the government of India recommends is that we will give levonorgestrel as single dose tablet. Single dose tablet. It is given as 1.5 milligrams of levonorgestrel. It is to be taken within 72 hours of unprotected intercourse. The female has to take this 1.5 milligrams of the single dose levonorgestrel. This single dose levonorgestrel is now available in the government of India by the name of Easy Pill. Easy Pill. This Easy Pill is single dose levonorgestrel, which is available by the National Family Planning Program. So this is the female can take it. Also, and this Easy Pill is also available under the SMS package. What is SMS? SMS stands for the Social Marketing Scheme. So that means that the ASHA worker can deliver these Easy Pill tablets. This is rupees 3 for one packet of the Easy Pill. So the ASHA will get rupees 3 for one packet of Easy Pill. So please remember that ASHA can give the condoms for home delivery. ASHA can give the Ocipills, Mala D tablets for home delivery. ASHA can also give the levonorgestrel Easy Pill tablets for home delivery. That is what is the Easy Pill. So what are the other contraceptives apart from the levonorgestrel? So we have heard about these contraceptives, right? We talked about the USP method, intrauterine levonorgestrel. We can also have another one, that is giving the mifepristone. Mifepristone is not taken as recommended as the first line or the second line. The first line is Easy Pill. Second is IUDs. Third would be mifepristone. It is given at the dose of 10 milligrams to be taken within 72 hours. Please do not answer mifepristone as 100 milligrams or something. That is the dose for MTP, abortion. So over here, we are going to protect unprotected intercourse, right? You're going to prevent a fertilization. So the simple answer for mifepristone is 10 milligrams to be taken by the female within 72 hours. So based on the understanding of these emergency contraceptives, MCQ which can be asked to you, that what are the indications, beta? You need to study that what are the indications for giving these emergency contraceptive. Which emergency contraceptive we talked about? The IUDs, the LNGs, the mifepristone, or the USP method. So what are the indications in case of a female or the male, right? Whatever, they were using condoms. In case of breakage, common sense, right? Breakage or leakage or the tear of the condoms, we may use the emergency contraceptives. In case of Ocipills, if the female was taking Ocipills and she is supposed to take Ocipills every day, right? There were 28 tablets and she's supposed to take it every day. In case the female misses 3 doses of the OCPs or more, 3 or more doses are missed, the female needs to take emergency contraceptive and use alternate contraception. Usually talking about is the barrier methods. Next in line regarding the progesterone only pill. See, POP has a special problem. POP is again to be taken every day. The problem with POP, progesterone only pill, is that it has to be taken at the same time every day. If the female forgets, I know it sounds so difficult for a female, that the POP, if it is delayed for more than 3 hours, the female might need to take emergency contraception because there is a higher failure rate expected. So for female who's on POP, if she misses the dose or delay the dose for more than 3 hours, it is an indication for taking the emergency contraception. Regarding norethistron enanthate, the NET-N, if the female, you remember that was injectable contraceptives. So the intramuscular injection should be taken every 2 monthly. If there is a delay of more than 2 weeks delay, that we will call for emergency contraception for NET-N. For DMPA, if there is more than 4 weeks delay. You remember NET-N was supposed to be given every 3 monthly. Now if the female turns back that I took the injection 5 months before, so now the female has missed for more than 2 months now. That is definitely a call for use of emergency contraception and use of alternate methods, and then we start with the DMPA back again. Or common sense, in case there is dislodgement or the expulsion of the intrauterine devices, or there is miscalculation of the for the menstrual phase, menstrual cycle. If there is any miscalculation or gross errors, again, these were marked the use of the Easy Pill. Easy Pill is given under the social marketing scheme by the ASHA worker in India. So with that, we cover most of the questions which can be asked on the temporary methods of contraception. We've talked about the natural methods, barrier methods, intrauterine devices, oral contraceptive pills, implants, injectables, other methods, and Cromans, Haley's, and all these things. Now let us move to the next topic, that is the permanent methods of contraception. Talking about the permanent methods of contraception. The permanent methods of contraception can broadly be classified. A person could be a male, that is, we are doing vasectomy, or the person could be a female, that is, we are planning for tubectomy. So broadly, we can classify into vasectomy or tubectomy. First MCQ, which is what is the most common operative method? What is the most common operative technique? Beta, for vasectomy, we almost always use the non-scalpel vasectomy. We don't do open vasectomies anymore. We do a non-scalpel vasectomy. For tubectomies, we can either do the mini laps, which can be done even by MBBS doctors, or we can do a laparoscopic tubectomies, of course, which is done by a trained professional gynecologist. The most common operative technique used in tubectomy is to cut and to ligate and to stump them together, the tubes. You need to ligate them, you need to cut them, and you need to stump them back into the area, into the pelvic area, and that is called as the modified Pomeroy's technique. It is the modified Pomeroy's technique for tubectomy and non-scalpel vasectomy for vasectomy. In terms of the cost, in terms of the money, if we talk, what do you think is more cost effective to the government of India? Please note that in the amount in which we can do one tubectomy, we could actually land up in doing 5 vasectomies. So if you do 5 vasectomies, that is equal to the amount of one tubectomy. So which is more cost effective for the government of India? It is vasectomy is always more cost effective. Couple of questions. Tubectomy is one topic which you will do much more in detail. I'm nobody to talk to you about tubectomies. You will do much more in detail in gynae section. Over here in community medicine, let us have a few words about vasectomy over here. So, bache, whenever we are planning for vasectomy, the person will get a vasectomy. So you split open the fibers. The fibers are split open. They are never cut. That's why we say it's a non-scalpel vasectomy. So we split open the fibers. We find the vas. We just cut it and we ligate it and we put it back. So that's a simple ligation of the vas difference. So what could be the complications? MCQ, what could be the complications which could arise from a vasectomy? So one complication that the examiner may be asking you, one thing I don't want to write down is simple, that the pain may be there, the infection, the chance of infection will be there, right? That's common sense. After every operation, pain will be there, infection will be there, which is the most common side effect. Common sense, pain is the most common side effect. There's no MCQ on this. MCQ which can be asked to you, bache, is that there is a formation, there could be a chance of formation of the spermatic granules. What is the sperm granules? The sperm granules, MCQ, the sperm granules can be formed after day 10 till day 14. So they can be formed within day 10 till day 14. They are usually 5 to 8 millimeters hard mass, which can be palpable, which is felt. Please note that these sperm granules are just because the sperm was there in the vas difference, and these sperm granules will be there and they cause this formation of the spermatic granules, and they are self-limiting. You don't have to cut open the person again. So you don't need to cut open the person. They are self-limiting. Please mark this word. What is the treatment can be asked to you for spermatic granules? Nothing. They will go off. So we just have to reassure the patient. It's okay. It happens. Next. There could be another MCQ regarding the antibodies. There could be autoimmune response. There could be antibodies to sperm. Now, do you know that in a non-vasectomized person, in a person who's not been vasectomized, in those people, normally in non-vasectomized people, normally occurring in like people, normally who's non-vasectomized, normally 2% of the people will generally have anti-sperm antibodies. In people who get a non-scalpel vasectomy or any vasectomy done, After vasectomy, the anti-sperm antibody usually increases. 54 to 55% of the people will develop the anti-sperm antibodies. The anti-sperm antibodies have not been linked to any disease. So again, we need to reassure the patient that nothing has to be done. There is no problem with these antibodies. They are not going to harm you. So there is a reassurance only which needs to be done. Now there is a point over here. Because there is formation of the anti-sperm antibodies, usually in normal people who have these anti-sperm antibodies, definitely their sperm will not mature, and definitely they'll have that problem of infertility or sterility, whatever. Now, in case we vasectomize a person, we cut the vas deferens, so there is a production, there is 50% chance that the people will land up with the anti-sperm antibodies. So now after 5 years, the person wants to recanalize. So if the person wants to recanalize, now this person is going to have the anti-sperm antibodies. So therefore, now the person will face difficulty in becoming a father or a parent again. So that's the problem. You do reassurance, but there is another MCQ which is linked to the anti-sperm antibodies. Its importance is not linked to any pathology. The importance is only that in case of recanalization, the return to fertility, mark my words, the return to fertility is a problem. Because once you recanalize, the return to fertility will not usually not happen because of the anti-sperm antibodies. So people should be told about this. There are some other side effects. There are some other complications which can arise after vasectomy. I think we are on the point number 4. The point number 4 complication which can arise is a spontaneous recanalization. So that will be a horror for a male, right? Recanalization. So that will be a horror for the male or for the family. The spontaneous recanalization usually is 0%. There is very less chance, or maybe it has been seen to 3 to 4%. Highest is 3 to 4%. So you can say that spontaneous recanalization, is it uncommon? Yes, it is definitely uncommon and rare. But is it not possible? Definitely no, it is possible. Spontaneous recanalization. Vas deferens is a tissue of the body, and any tissue can recanalize. And 5th would be the psychological complications or the psychological support for a male. So these are regarding the vasectomy's complications. There could also be some questions regarding the specific post-operative advices which we are required as medical professionals, we are supposed to give to the person, to the male. So after a person gets a vasectomy done, immediately they should be using alternate contraception. Alternate contraception should be used, otherwise it comes under the medical negligence of the doctor if they are not able to counsel the person that there has to be a alternate contraception used. So just imagine that a person comes to you, he says that I'm ready for vasectomy, doctor, and you say that fine, we'll do the vasectomy but for the next 2-3 months minimum you should use other types of contraception. So you have to tell this before we do the vasectomy. So it's actually not a post-operative advice, it is a pre-operative advice that use of alternate contraception has to be done after vasectomy for 8 to 9 weeks, minimum 8 to 9 weeks, minimum 2.5 months to 3 months, or for 30 ejaculations. That is just for your MCQ purpose. Practically, we do not talk about 30 ejaculations. It's roughly around 3 months the patient has to use alternate contraception. The person, that's a general point, that the person has to keep themselves clean and hygienic. No weightlifting for 15 days, no weightlifting for 2 weeks. The follow-up is usually scheduled around day 5, again at day 10, again at day 15. So every 5 days the follow-up is usually done for the patient for finding any infection or anything. So the patient should be using a langote or a T bandage for support of the testicles for 15 days. The patient should keep the area clean, hygienic. The patient should not take bath immediately. They should take bath only after 1 day. These are some simple post-operative advices. The failure rate of this contraception, of this vasectomy, is roughly around 0.15 per 100 women years. It's a very low failure rate. What is the most common reason for this failure rate? This can be asked in your exam. What is the most common reason for failure? What is the most common reason for failure of vasectomy? Please note that the most common reason for failure of vasectomy is misidentification of vas deferens. So misidentification of vas deferens is what is the most common reason for failure. So what we have seen till now is the permanent methods of contraception could broadly be classified into tubectomies or vasectomies. We can still have another method of contraception that, let me name it as other methods, and let me just walk you through that what is this other method of contraception. You can just have a look at yourself. So now as we cover the topic on vasectomy and tubectomy, there is still another method of sterilization that could be like, let us call that as other methods of sterilization. And now let me walk you through this. What is this other method of sterilization? Let us say, bache, that this is the uterus. If you just look at the uterus, and let us assume that these are the fallopian tubes, and then in the end you have the ovaries, and then there is the fimbriae and all that. So let us say that in the fallopian tubes, if by chance, if I can insert some coils into it, don't you think that the coils are going to cause fibrosis in the fallopian tube? So now, if you insert the coils in the left fallopian tube and the right fallopian tube, both areas, so technically there will be fibrosis after few days or weeks or months. So if there is fibrosis, your job is done. The ova stays here, the sperm will stay here. That is what is a permanent method of sterilization. So MCQs now, what is this coil called as? These coils are called as microassure. Microassure. And what is this technique called as? It is called as assure technique. If you insert coils in a female today, will she become sterile immediately? Answer is no. How can she become sterile immediately? She will need some time for developing the fibrosis. MCQ, how much time for fibrosis? The microassure we will say that the fibrosis probably will happen after 6 weeks. So very simple procedure. Take an endoscope. Endoscopically, you insert the coils in the left and the right, microassure in the left and the right. Wait for 6 weeks. After 6 weeks, do we say that the female is sterile by herself? No, you should check the female. How do you check? You do hysterosalpingography. Hysterosalpingography, HSG. So that is why this method, the coil is very expensive. You need to wait for 6 weeks. There could be some unwanted side effects, and there is expensive hysterosalpingography also which is involved, and therefore this method is not very, very commonly practiced, but it is one of the methods for permanent ways of sterilization. That is the other methods, that is, you can call it as assure technique. This is what is, we can call it as assure technique, right? So that covers everything, almost everything. That actually covers almost everything about the temporary methods of contraception as well as regarding the permanent methods of contraception. Now I am closing over to the next topic in contraception. What do you mean by the contraceptive effectivity? If you have remembered all these contraceptions, what do you mean by the contraceptive effectivity? Please note that OC pills are known to be almost 100% effective, 99.9% effective, we can say. IUDs are known to be 95% effective, and condoms are known to be around only 60 to 70% effective. So we can say that which is the most effective contraception. Please note that the most effective contraception is oral contraceptive pills. It is not intrauterine devices. Next in line is, what do we mean by the equivalency sterilization? It might be a slightly difficult topic for, especially for the third year students or the UG students, but all those who are preparing for post-graduation entrance exam or the interns, you'll be very fast, you'll be able to catch it. Let us say that this is the village and you are the medical officer of health in that district or in the village. So there will be common sense. There will be people who are using condoms. There will be people who are using IUDs. There will be people who are using OC pills, Antara, injectables, something, different things, different people will be using. You as a medical officer of health, you want to see that how many people are sterile, okay, sterilized in terms of the temporary methods also. So very soon you'll understand what I'm saying. Let us say that one tubectomy is done in a village. So common sense, that means how many sterilization? That means one sterilization. If you do one vasectomy, that is also equal to one sterilization. One sterilization. Now, if we put 3 IUDs in females, 3 IUDs is inserted, that is the copper T380, it is also called as one sterilization. You'll ask me that how is it possible? See, if we insert IUD copper T380 in a female, you put it once, twice and thrice. So 10 years, 10 years, 10 years. Yeah? That's the lifespan. So total is 30 years. What is the WRA period? Roughly around 30-35 years. So we can say that 3 IUD in one female is sterile. So 3 IUD in 3 different females will also be taken as 1 unit of sterilization. So in simple words, we are just calculating what is the unit of sterilization. Please do not take this mathematically that you start doing it for every contraception. It doesn't happen like that. In general, I'm just telling you the concept that how many are the temporary users, how many users will be equal to one permanent sterilization. That is what this concept is. Please also note for your exam, you just need to memorize the numbers. That's all. So for your exam, you need to know that 9 OC pill users. How many? 9 OC pill users is equal to one sterilization. MCQ can be that who is OCP user? When do you call a female as OCP user? If this is a female and she started taking OCP just this month, is she a OCP user? When will you call this female as OCP user? A OCP user is a user who has used oral contraceptive pills for more than 11 months in a year. In the last 1 year, if a female has used for more than 11 months, that is called as OC pill users. On the similar principles, we will say that 18 condom users. 18 condom users is also equal to one sterilization. MCQ, who is a condom user? Condom user is a person who has used 72 condoms in a year. That is called as equivalent condom user. So all these have been previously asked MCQ. What is a condom user? Person who uses 72 condoms a year. Who is OC pill user? A female who has used 11 months of OC pill cycles in a year. And IUD is a person who's got a IUD copper T380 done. So these are what are the equivalent sterilization. Next MCQ for you is what are the contraception of choices. What are the contraception of choices? A 3 by 5 star MCQ topic. Last topic, just to close off this chapter on contraception, is contraception of choice. Scenario number 1. Let us say a female comes to you. She is unmarried. Unmarried girl comes to you and she is sexually active. She takes your contraceptive advice. What is the advice you would like to give? Which of the following contraceptions? Let us say that the options that I give to you is, are we going to talk about the barrier methods or the condoms, the oral contraceptive pills, the intrauterine devices, the Antara injections? Or do we give the Chaya tablets? Chaya is what is the Saheli or the Centroman. Antara injections, Chaya tablets, or we do tubectomy, or we do vasectomy. So what do you think is the best answer over here in this female unmarried girl sexually active? Please note that the best answer over here is a barrier method. Barrier method, you cannot afford to answer in your exam without a barrier method because not of the fact about the preventing pregnancy, because it's an unmarried girl and sexually active. Always think of multiple sexual partners. So in Government of India, the guidelines are that unmarried girls sexually active, we have to go with the barrier methods. However, the MCQ may say that what is the ideal contraceptive? Why? Because the barrier methods will have a higher failure rates, right? You are more bothered with preventing the RTI, STI rather than the pregnancy. But barriers will definitely have a higher failure rate. So what is the ideal contraceptive? Please note that the ideal contraceptive is OC pill plus a barrier back again. You cannot answer without a barrier. So what is the ideal contraceptive? If you get 2 options, answer is OC pill plus the barrier. If you get single best answer, please mark barrier. Second scenario. Let us say that there is a female who's married, a married female. She comes to you and she says that I never want to have children in my life. She does not want to have children. She is currently nulliparous and she doesn't want to have children. She'll probably adopt children or things like these. What is your best contraception? Options are barrier methods, OCP, IUD, Antra, Chaya, tubectomy, vasectomy. Please do not answer if you're thinking of in terms of tubectomy. Do not answer tubectomy in this female. So this female is married, but she is not wanting any children now. She's not wanting any children afterwards also, whatever the exam may say. Never answer tubectomy over here, because you should know that what are the indications for tubectomy. The indications for doing tubectomy is that the family should have been completed. That is, the female should have completed family or should have at least one child, So that is the criteria for doing a tubectomy. In this female, you cannot tubectomize just because she says that I don't want to have children. If you do tubectomy, what if she comes back after 5 years that I changed my mind? So you can't do the reversal of tubectomy every time. So please note that what is the contraception, ideal contraception you would like to give over here. Do not answer the IUDs also, because intrauterine device is something which is you are going to put inside the uterus, right? This female who's coming to you, she's not having any children right now. She's nulliparous. So the cervical os is closed. Why do you want to insert something? So please note the ideal contraceptive. I think many of you must have got it right. Answer should be the ideal contraceptive is the oral contraceptive pills. Let us say third MCQ that there is a married female. She already has one child and she wants to delay the second by 3 years or 4 years. So what is the contraception of choice? Now I think you are free to mark. You can mark occipils, you can mark IUDs. Why IUDs? Because the cervical os is open. This female already has delivered a child. So please note that IUD would be a much better answer over here. Intrauterine devices, these are also called as spacers. Intrauterine devices, these are also called as spacer devices. Fourth point, let us say a married female is there. She already has 3 children. And she comes to you and she says that I want to delay the 4th. I know this is a very hypothetical example. In your exam, you will probably not get this funny type of MCQ. But let us say a married female is there. She already has 3 children and she wants to delay the 4th. What is the best contraception? In case you're talking about tubectomy, that's again a wrong answer. Answer is vasectomy, because we are looking at cost effectivity also. The one which is Sasta Sundar Tikau, the one which is more cost effective for the government of India, we are going to advocate that. Of course, your best answer is vasectomy. If vasectomy not there, please mark tubectomy as your best answers, right? A fifth scenario, let us say that a female comes to you, a female who's married and she comes to you, and let us say that she wants to delay her first child. She wants to delay the first child. What is the best contraception? Answer would be definitely, I think you all have understood over here. She wants to delay the first child. Barriers can be an answer, but barrier will have a high failure rate. The ideal answer would be occipils. Why occipils? Because they can be given to young females. So she's probably newly married. She wants to delay the first child. IUD cannot be given because the female is cervical os is closed. So the best answer would be occipils. But let us say that the female says, I don't want to take occipils. Probably it will cause weight gain or things like these. So do you have something in Government of India that you can give? Answer is definitely we can go with the Antra or the Chaya tablet. Chaya tablet, whenever the question will say that the female is educated, only in that scenario think of Chaya. Otherwise, we don't think of Chaya, because Chaya would require a very high female level motivation, because you cannot afford to miss Chaya tablets even for 1 day. So Antra injections can duly be given to this female, or we can have Chaya tablets. But yes, the ideal answer would be oral contraceptive pills, right? So that is all that you require. Just one point about effectivity of the contraception. We talked about the effectivity of the contraception. Please note that if we are talking about the effectivity, some of the IUDs, you remember what was the Pearls index for IUDs? IUD is 0.7 to 1.5. Pearls index, that is per 100 women years. Please note that there is one IUD, that is Mirena. Mirena has the lowest failure rate. So in Government of India, the most effective contraception that we have is either OC pills or we have the Copper T 380 or the 375. But in overall, if they ask you in private sector, which IUD has the lowest failure rate, answer has to be Mirena. Please note, Mirena has a lowest failure rate. It ranges from 0.2 to 0.3 per 100 women years. So generally talking, IUDs will have a failure rate between 0.7 to 1.5. But Mirena is the only one which has the lowest failure rate. I would also like you to mention over here that Progesta Cert, it is one IUD, intrauterine device, which is a hormonal. It has the lowest expulsion rate. So please note that Mirena has the lowest failure rate, but MCQ which can be asked to you is that which contraceptive has the lowest failure rate? Answer is Implanon or Nexplanon has the lowest failure rate. They are the most effective contraceptive. Most effective contraceptives, they are in tune of less than 0.05 per 100 women years. The failure rate of tubectomy and vasectomy is also 0.1, but Implanons are most effective. Implanon and Nexplanon, these are most effective contraceptives. So now all the essential requirements for your PG entrance exam or UG exam, prof exams, we have covered them all regarding the contraception, temporary methods and permanent methods, and evaluation of contraception. Now, this section is for all the nerdy people who still have that adrenaline and who still want to learn something extra. This is the nerd corner for you. Topic number 1, what are the male contraceptives, or which are the newer developed male contraceptives? One is regarding Gossypol. We already have talked about Gossypol. Gossypol is a Chinese natural extract and it inhibits the spermatogenesis, right? That's pretty simple. We have already talked on this. This is age-old thing. It's nothing new about Gossypol. Next in line, what is this Catspur gene? Catspur blocker. So basically, calcium ions will be required for the sperm motility. Am I correct? You already know that the calcium ions will be required for sperm activation and the motility. Now the calcium ions are available in the testicular area or in the vas for sperm motility. This calcium ion is via a calcium ion channels, and the gene which controls the calcium ion channels is called as the Catspur gene. And now researchers have developed the Catspur blockers. So we now have the Catspur blockers. The research is still on upon the route of administration, but surprisingly, the Catspur blockers can be used in both males and in females, and it has shown some effectivity in both males and females. But it's a Catspur gene blocker. That is what is one level of contraception that we can think of. Another types of contraception that could be a drogesterol male pill. What is drogesterone? That is desogestrel, right? That is desogestrel. Now, desogestrel is given along with the transdermal, can be given along with the transdermal testosterone patch. And this desogestrel in the tune of 300 micrograms along with the 5 milligram of testosterone, it has shown to have a good efficacy. So now it is shown to inhibit spermatogenesis. Therefore, it can be used as a male contraceptive, but there is a certain disadvantage which is linked with this drogestrel male pill, that the disadvantage is that it may be associated with electrolyte imbalance. What is this adjudin? Adjudin is nothing but an anti-cancer analog. It is lonidamine analog. And it is actually a anti-cancer drug. It is a hormonal male pill which has shown to inhibit the spermatogenesis or the sperm maturation, to be more precise. Next is, what is this RISUG? RISUG stands for reversible inhibition of the sperm under guidance, that is RISUG. Bache, the RISUG, RISUG, it falls under the category of the vaso-occlusive contraceptives. We may call them as the VOC or the intravasal devices. IVDs, that is the intravasal devices. Just like you remember, we had talked about the Assure technique where the fallopian tube, you put the coils and they are blocked. And the similar principles, you can take the vas deferens and you block the vas deferens. So obviously the sperm is blocked. So one way is to give these valves. These are intravasal control valves called as bionics. Another way is we can put the vaso-occlusive plugs or gels. The vaso-occlusive plugs could be containing any synthetic materials. They could contain any synthetic materials. They could contain any polymers to have occlusion of the vas deferens, or we can have the installation of these. We can have the installation of these, what we call as RISUG. RISUG is using a material that is styrene, maleic anhydride. So this material, it's a polymer material. Once it is injected inside the vas deferens, it will cause occlusion and it will also destroy the sperms by throwing an electrical charge or some biochemical changes which causes destruction of the sperms, and it blocks the vas deferens. So that is what is RISUG, that is reversible inhibition of the sperm under guidance. So these are some of the newer techniques specifically talking about the male contraception. Talking about the immunocontraception, we can also have developed, the scientists have developed, the researchers have developed some of the vaccines for contraception. We can either talk of immunocontraception at the level of the hypothalamus or the pituitary. At the level of the hypothalamus or the pituitary, which are actually producing the hormones, that is the gamete production. So we are talking at the GnRH vaccines, we can talk about the LH vaccine, we can talk about the FSH vaccines. Regarding the gamete function, that is those to stop the gametes, so we can either have a sperm vaccine that is going to destroy the sperms, or we can have a zona pellucida vaccine. The gamete outcome can be assessed, can be protected in terms of the HCG vaccine, which can prevent the gamete fertilization and the development, not the fertilization, the zygote development. So they will stop at the very initial embryogenesis phase. That is what is HCG. The zygote development requires HCG. So if we have a HCG vaccine, it will stop the further process of embryonation and all that. So these were some of the recent advances or the latest techniques that we have in contraception. Coming to another recent advance is that the WHO, the World Health Organization, the big daddy in health in the world, the World Health Organization, they have made a special card kind of thing. There's a wheel. I hope you must have seen the BMI and the nutrition and the weight wheels, where we have the wheels and you just rotate that. This is the weight of the person and the wheel is going to rotate. So the wheel is there. This is the base of the wheel that you are seeing right now. And this is the front of the wheel. So can you see that the front of the wheel, how many contraceptions will be assessed? So here you will get the number 1, 2, 3 or 4. So what do you mean by 1? 1 is the method in any situation. So that means 1 is the indicated method. 4 is the method not to be used. Okay, 2 and 3 is with restrictions. So technically speaking, this wheel will tell you what it will tell you, that whether these 9 contraceptions, this method, WHO method, wheel method, is for 9 contraceptions. It is going to tell you that whether these 9 contraceptions, can they be used in what situations. Can you see this very small written? It is, we are talking about the breastfeeding, the liver disease, venous thromboembolism, cardiovascular disease, obesity, diabetes, smoking, headaches, medications, HIV, so on and so forth. So there are various conditions. So if you match the conditions of a person, and then you can see that which all contraceptives can be advised or not advised. So this is called as the MEC wheel, the medical eligibility criteria wheel given by the WHO. So in this wheel, please note there are 9 contraceptives we are assessing. We are going to talk about the contraceptive pills, that is the oral combined pills, contraceptive patches, vaginal rings, combined injectable contraceptive, progesterone only pill, injectables, implants, levonorgestrel releasing intrauterine devices and copper intrauterine devices. So these are the things which are assessed in this wheel, and that is what is the utility of wheel. It will tell you that whether the contraceptive is eligible to be given in one contraception, yes or no. And so with that, as always, thank you very much for learning this module with me. And in the next module, you will be eligible to understand the National Family Planning Program at the country level.